Good morning to everybody. It's an honor for me standing here. So let's start to discuss about the topic Professor Markopoulos just announced. Access seats, are they really necessary? Are they a friend? Starting, there is no conflict of interest. And I would first like to say that the decision to use or not to use a urethral access sheath and the decision which one from those available in the market we will use is based on the preoperative evaluation and the intraoperative findings in each case. What about the guidelines? The AUA guidelines recommend urethral access sheath in complex, high-volume renal stones, while EAU guidelines depends on surgeon preference. This is the first meta-analysis to evaluate the efficacy and safety of the urethral access sheath during ureteroscopy and provides evidence for everything we will say from now on. The main and the important thing that this study indicates is that there was a significant difference in favor of not putting an access sheath during our process about the post-operative complications. But in this meta-analysis from 5 countries and 8 studies included, 2 RCTs and 3,099 patients with 3,127 procedures. It's really important that the post-operative complications were higher in that group. So, and the intrinsic restriction, though, like low quality, we can see here, score of the included studies, is very important also and indicates that we want more studies to confirm and update these findings. About the stone-free rate, the only predictive factor, as we can see in these diagrams, was the stone burden. You can see here that the post-operative complications was higher in the UAS group. And here, in this table, that the stone burden in every study was the real predictive factor that matters. So, going on, this is another important study by the Clinical Research Office of Endourological Society, involved the collection of prospective data from consecutive patients treated with URS in centers around the world over 1 year. 2,239 patients treated with flexible URS, 67% with urethral access sheath and 33% without. In that study, the important thing is that there was no difference in stone-free rate. There was no difference in the risk of urethral damage or bleeding, and the post-operating infectious complications were reduced in the arm of the urethral access sheath. Also, the intraoperative complication rates were favorable in that arm. So, that study tells us that we have to put a urethral access sheath during our procedures. So, if we summarize the benefits of the use of the urethral access sheath, from all the existing studies, we can say that improves the outflow, reduces the intrarenal pressure, lowers the irrigation pressure and reflux 57 to 75%, and that's why reduces also fever, UTIs, and sepsis. Here we have to say that 10-12 and 12-14 urethral access sheaths keeps pelvic pressure stable of 20 to 30 centimeters of water, and even with irrigation pressure very high. So, going on, again, improves outflow, improves irrigation, improves vision also. It's easier to enter and re-enter in the system, in the collecting system, and more safe, and protects also our scope. About the basketing, makes basketing easier and safer, and about the stone-free rate, I think it's good, but if it's better or not, it's controversial. There are many studies that say the one thing or the other, and we need more studies to define that. This is another study, 7-year period, and prospectively from 2012 to 2018, 338 patients, two groups, 60% with a urethral access sheath and 40% without. The stone-free rate, as you can see here in this table, it's for both groups very good, 88 to 94%. So the use, according to this table, the use of the urethral access sheath is safe with no intraoperative complications. Now, if we try to summarize the studies that support the defects of the use of the urethral access sheaths, here we have the prospective evaluation and classification of wall injuries, endoscopic classification, of 359 patients at 2 academic centers, and urethral wall injury was found in 167 patients, and severe injury involving the smooth muscle layer was observed in 48 patients. Males and olders were at higher risk for severe injury, but the most significant predictor of severe injury was the absence of the urethral JJ stent before our surgery. So here is another study to compare two commercially available urethral access sheaths in their ability to assess the renal collecting system and assess the urethral wall trauma. Here we have to say that both, as you see, it was 12-14 French access sheath, Cook Flexor or Boston Navigator. The overall successful placement was almost 88% for both sheaths, equal success, and the risk of injury was associated with male gender, large stone, long insertion time, and more difficult subjective rating for sheath placement. Here we have to add that the Navigator was successful in 43%, it's a high percent, of the failure of the Cook Flexor. So it was rated as the easier to place. there was no significant difference in the urethral wall injury between the sheaths. And also we have to add that the surgeons must switch easier to a smaller sheath if they feel resistance, or if the insertion time goes on and it's very long. So from a greater access sheath, we have to try and put a smaller one. As you know, there are many different sheaths available in the market, and this is a systemic review of the preferred reporting items for, and this is a meta-analysis on this topic. The use of urethral access sheath demonstrated several advantages to facilitate retrograde intrarenal surgery access, lower intrarenal pressure, as we said before, protect the ureter, protect the scope, and facilitate the stone extraction. Despite this, though, there is also some evidence that urethral access sheath use may be associated with acute urethral injury and long-term complications related to maneuvers that we do during our insertion, and mucosal or deeper layer injuries and ischemia. There are also still many questions on the possible increase in stone-free rate and decrease in operative time, and also the costs. Here you can see the available urethral access sheaths, as we all know, in the market. And here we can see the fitting of those access sheaths with our urethroscopes. Another study here showed that there is no long-term stricture rate after high-grade injury is similar to those without visible injury. So practically there is no great difference. From 2010 to 2015, with the use of 1214 access sheath, they had 56 high-grade injuries, and in 36 months of follow-up, they had 3 de novo hydronephrosis and only 1 stricture. So, how can we avoid a possible lesion? I think we can do it with care. we have to handle our access sheath very gently, never force the access sheath. The period of time, the time of insertion is very important. It has to be short, and the pre-standing, if this is possible, increases the insertion of the access sheath 88%. Or insertion of dilator or passive dilation. I think using a small sheath or a smaller sheath is better, because if we use a large urethral access sheath and our working channel is occupied, the outflow decreases. So this is not very good, especially in some occasions, infectious stones, etc. So, about the access failure, 10-12, 3%, very low. 12-14, 10%, low. Now, what about pediatric urethroscopy? There is a study to confirm the use of urethral access sheath, even in children, in treatment of pediatric renal stones, and proves that it is safe and feasible with very good outcomes, as you can see, and without any long-term complications. What about the future? Here, we have to mention the vacuum-assisted urethral access sheath, the access sheath force sensor, and the expandable sheath. And from all these, I would like to present you that study about the access sheath force sensor that practically says that urethral injuries can be prevented by limiting the insertion force to 6 newtons, equal to 6 newtons or lower to 6 newtons. Also, we can prevent the injuries with pre-standing, plus oral tamsulosin and recently treated bacteriuria. This, in that study, favored the passage of 16 French urethral access sheath, which is very important. Also, in the naive and unstented patients, preoperative tamsulosin favored also the deployment of a 16 French urethral access sheath. So, what about the sheaths? Yes, but not routinely. Especially, we use it if we have large stones. We have to deal with large stones greater than 1 centimeter. And if we know that our operating time will be long as we are safe. And when we have infective zones. And summarizing, our guidelines depends on surgeon preference. In this point, I would like to add the last thing, that also there are studies that says that the proximal urethral diameter also is associated with high grade urethral injuries. So in some centers, the preoperative non-contrast CT they do to measure the ureter, it can be very useful to prevent the injuries. Thank you very much.